Let's start off the second part of chapter 22 with a fun word to know and tell. It is bifurcation, and it is a place where something splits off. So here is a bifurcation going off this way and that way, and here's another bifurcation, and here's yet another bifurcation. Now, we are finally at the business end of the lung, the part that actually does the stuff that we want to be done. These are all hollow. On the outside, you have little capillaries that are coming in, picking up oxygen. I have that backwards. Coming in, picking up oxygen, and leaving. You have to use the blue, meaning no oxygen, and the red, having oxygen. Remember that the cells that make up these bronchioles are ciliated cuboidals. So cuboidals can secrete and absorb, and ciliated can push. So fluids can be pushed up and out and away from the alveoli. Now, we have cells in the alveoli that make surfactant, but the majority of the cells that make up the alveoli and the ones that make up the capillary are the squamous epithelium. So if you were to zoom in right here and look at this, the part that they've got kind of a, is that a taupe color? I'm not really into my colors. Would be the cells, the squamous epithelium of the alveoli. And then the red and the blue would be the incoming capillaries and outgoing capillaries. So squamous epithelial, so it is very, very thin with basically two cell layers. And the one thing you can't see, but there's a little bit of connective tissue in there. We call it basement membrane. So for those of you who are dying to know what basement membrane is, it is hydrated collagen and glycopeptides. So if you remember when you did the chapter on histology and you learned about the different cell types, and we looked at the connective tissue, you have the really, really strong connective tissue that makes up the ligaments and the tendons, and they are really full of collagen fibers. So to put it in your mind, think of strapping tape. Strapping tape kind of looks like Scotch tape, except for it's got filaments in it that makes it really strong, so it's really hard to tear it. You almost have to have scissors. You can't bite it through with your teeth like regular Scotch tape. So imagine the two layers of squamous epithelium with some of that collagen fiber and a little glycoprotein in there to kind of make it hold it together. One of the things I think makes learning anatomy physiology a little bit unnecessarily hard is that they're constantly changing the name of things, which is disconcerting. And the like endothelial cells, they named it that to let you know that it is inside the blood capillary, so it's the lining of the capillary. It actually makes up the capillary itself, except for the shared basement membrane outside of it. If the same cell was on the outside, we would call it epithelial cells, and they are squamous cells. So endothelial, you got to think, oh, those are just squamous skin cells. They just happen to be on the inside of the blood capillary. Sometimes these slides state the obvious. Here's one of them. Fluid in the lungs can be fatal. Well, we kind of know that. If you get in the water and you breathe in air, you're going to die. It's that simple. Because you can't get oxygen to go through the liquid enough to get across the squamous epithelial cells, the basement membrane, and across into the capillaries. Now, we did see in the last episode that there is a fluid that you can actually put oxygen in, and it will allow the fluid to transfer over. So this is how we can save babies who don't have the ability to breathe yet. Their lungs aren't completely ready and they don't have the surfactant that they need to hold their lungs open. And so we can put that fluid in there and deliver oxygen to them through the fluid. And I had a very unique and unusual physiology teacher, and at EKU they actually have a room named after him, which I was very glad to see that they did that. And he just with a straight face said, I believe that they could make a fluid that they could pump in your intestines that would be full of oxygen, and you wouldn't even need to breathe. You would just get the oxygen that you needed diffusing out of your intestines. And then when you were done with it, you could just release it from your intestines. And I just remember sitting there kind of with my mouth hanging open saying, I don't think he actually just said that. Now, when you consider that I had him as a teacher 50 years ago, his prediction of them finding that fluid that you could saturate with oxygen and put in the lungs was like foreshadowing. He was able to see into the future where things were going to go and predict that. So I thought that was kind of neat as I lived through the last many decades and saw a lot of the things that he predicted come true. So that was one of the things. Yay. Go, Dr. Jones. Can you imagine scuba diving without having to have a tank? That would be awesome. You don't have all that noise and the weight. All right, the alveoli are kept dry by low blood pressure in the capillaries. So if there was pressure in the capillaries, it's going to force the fluid out of the capillaries and into the alveoli. So we have very low pressure so that you don't get the plasma pushed out of the capillaries, because that would cause you to drown. And one of the first things that people who have lung cancer discover, the way they discover it, because again, it's not usually painful until it gets into the bones, but they are short of breath. They have trouble breathing. And because the cancer is in usually in the bronchial tubes, you end up with a lot of fluid buildup in the lungs. So I remember they would have to stick a needle in my father's back and aspirate the fluid out of his lungs just so he could breathe, because he literally was drowning in his own secretions because of the type of cancer that he had. Also, if you remember from the chapter on lymphatics, the lungs have more lymphatic drainage than any other organ in the body. So it's really important to keep the water, the fluid out of the lungs so that the air can go across. And here's a cartoon trying to show you putting all the things together. So you've got these cells that are making surfactant, and this kind of blue layer is the surfactant that covers each of the alveoli. Here's one of the dust cells, which is an alveolar macrophage. And then all around, if you do a cut through, here's a capillary with the red blood cells, capillary with red blood cells, we saw that were wrapped around the outside there. So now we've cut through and we're looking inside. And then this picture is showing you the basement membrane there. And then the squamous epithelial cells here. They don't show you the nuclei, so it's kind of not the best of all possible pictures. But you can see the carbon dioxide going out into the lungs so that you can exhale it and the oxygen coming in. So there's just kind of a summary of all the stuff that we've been talking about. Whenever you have a serous membrane, the side of the membrane, remember it's a double membrane, it's folded over, the side that touches the pleura, or the lungs, is the visceral side, and the one that's on the outside is the parietal. And this is going to be true for the heart. Anytime you have a serous membrane wrapped around, you're going to have the visceral on the inside and the parietal on the outside, and then there's a little space in between them and it has just a very thin film of slippery fluid that allows the lungs to inflate and deflate without causing too much friction. But if you get any kind of an infection in there, you can actually hear it. You can hear as those membranes slide across each other. And the pain is unbelievable because of the friction. Now we're going to get into a concept that's a little bit confusing, and most of you probably don't know that it actually exists. But so we have the membrane wrapped around the lungs, and of course, reduction of friction is one of the big things that it does. It also keeps infection from spreading out of the lungs into the body or out of the body into the lungs. So it's got to get through that serous membrane in order to spread. But here's one of the things. It creates a pressure gradient, which allows the lungs to inflate. So the pressure inside is lower than atmospheric pressure outside. As long as you don't have a wound where something has punctured your thoracic cavity, you will be sealed off in there at a lower atmospheric pressure. If you are stabbed, shot, someone gets you with an ice pick, whatever, and pokes a hole through, then the pressure of the air that's outside of you is higher than what's inside, and so the air will rush into the hole. And they call it a sucking chest wound. And the proper name for it, of course you can't just have a regular name, is atelectasis.
Atelectasis.
There you go. Just so that you know that I'm saying it right. And what happens is that air comes in, it collapses your lung. So you're not breathing through that particular collapsed lung. So they can rush you to the hospital and reinflate your lung. But before they can do that, they have to seal off the sucking wound. So I've seen them in movies and videos and things. You can take saran wrap, anything like that, and just lay it over the hole so that you can start building up the negative pressure inside. Keep the outside atmospheric air from rushing in and holding the lung closed. So that's what they're doing in this. And if you want to see more about it, if you want to be an EMT or something, you can watch some of the videos that are out there. A pneumothorax is the name of the situation where you're sucking the air in. So pneumo has to do with lungs, and thorax is the region where your lungs are, where you lose the pressure. So, and then if it collapses, then that's the atelectasis, or collapsed lung. All right, now we're going to talk about the breathing cycles and what we expect out of your lungs. How much do we expect you to breathe in when you inspire or inhale? How much do we expect you to exhale? And we're going to look at when you are just sitting around watching TV, chilling out, what they call quiet respiration. And then forced respiration, that's where you're gasping for air because you're jogging, you're running, you're playing basketball or something like that. So this slide is telling you basically there's more air outside of your body than there is inside your lungs. And because you have this difference in pressure, it drives the air across the membrane and into the capillaries. Now, if you happen to go on top of a mountain, one of the things that they're going to tell you, like if you go to Denver, the Mile High City, or if you go to Machu Picchu, like I did, which is unbelievably high, and the bus taking you up there is scary as heck. You feel like you're literally going straight up the mountain. But anyway, one of the things they tell you is do not run. do not do anything except for walk very, very slowly and take as normal a breath as you possibly can, because up that high there is less air, and so you actually don't have this pressure difference. And if you do like I did, I was fascinated by something, was staring at it, and then I looked up and I saw the group and they had started to move away and were going behind a building. And so I didn't run, but I walked very quickly over there. And when I got there, I couldn't breathe. And it was the scariest, most smothery feeling. And then I was thinking, okay, well, I know better. You know, I'm pretty smart about this sort of thing. And so I said, calm down, be really, really calm, and take the best breaths that you can, and you'll be okay. And so I did that, and I started breathing normally after a little while. But it was scary. So people who live high up on mountains, you can't cook things like beans. You know, you may be cooking for hours and hours and hours and hours, and they have to have a pressure cooker, and so they can increase the pressure and force the water into the beans that they're cooking. So this pressure differential is really important on the lungs. You've heard me say that breathing is not an act of the lungs contracting and expanding, but rather the lungs riding up and down on the diaphragm. Now, this is kind of opposite of what you would think, but when the diaphragm contracts, it makes your thoracic cavity larger and it pulls down. So your lungs, which are attached at the top, are pulled downward because they're attached with a kind of a fluid layer to the diaphragm. And so as the diaphragm goes down, as it contracts, it pulls the lungs down, and they get larger and they inflate. And then when you release the diaphragm, then the relaxation allows the diaphragm to bulge up. And as it bulges up, it pushes your lungs, and it pushes the air out of your lungs. So this riding up and down on the diaphragm is actually how you breathe. Try to remember the thoracic cavity, where you have the sternum and you have the costal cartilages that are holding the ribs, and then they extend around back to your vertebral column. And this actually makes a bony pocket for the lungs to expand and contract in. So that helps quite a bit, and it prevents your chest from caving inward when the diaphragm pulls down. So you actually have a bony pocket for them to sit in. In addition to the diaphragm, which is moving up and down, you also have other accessory muscles that help out. And the sternocleidomastoid, pectoralis major, erector spinae, you guys call these pecs. You say, ooh, look at my pecs. That you have the pectoralis major and minor, and the serratus anterior muscles and the scalenes. So you do have a bunch of muscles that help out. But the diaphragm is the main guy, and it's part membrane and part muscle. If you're going to do more than just sit quietly breathing, if you're going to have forced inspiration and expiration, then you're going to involve some other muscles. So the rectus abdominis and the internal intercostals, and some of the other muscles that make up your lumbar region, that's your lower back, your abdominal, that's around your belly button region, and your pelvic muscles even are going to help you. So if you see somebody taking a really deep breath, you can see all the muscles that you have to recruit to get all of that air in, and then and push all of that air out. So they call that abdominal breathing. So next time you're urinating or pooping, defecation is the word for pooping, notice what you do, that you do hold your breath. You take a deep breath, so you've inflated your lungs, you've got the diaphragm down, and if you close your glottis, you close the vocal flaps so air doesn't come out, and then you contract your abdominal muscles, you will push the urine out or you will push the feces out. I would suggest that you think about it and notice it when you're in childbirth or vomiting, but you're usually too busy to actually stop and say, wow, isn't this cool? Wow, look, I'm holding my breath and pushing down. You're welcome to memorize all the muscles. I'm not going to be asking you. Of course, I'm going to expect you to know about the diaphragm right there. But here's your sternocleidomastoid coming down here. And these are your costal cartilages. And inside you've got your internal intercostals and your external intercostals, your rectus abdominis, or what you and I would call your abs for short. So you know a lot of these muscles. Hopefully you learned them already, but this is a little bit of a memory thing. So any of these are going to be helping you when you're doing more breathing than just normal. But like I said, I'm not going to ask you that on a test. You just need to know the diaphragm for sure. When we studied the heart, we talked about the sinoatrial node, and that's the pacemaker, and it sets the rate at which your heart beats. There is no pacemaker set of cells that regulates your breathing. And here's something a little bit scary. The exact mechanism for setting respiratory rhythm is unknown. So as smart as we are and all the experiments we've done and all the books we've written, we still don't know what triggers you to breathe. And one of the things, well, we know that if you sever the spinal cord that you'll stop breathing. So we know that there's got to be some sort of neural control of breathing. But we also know that you have conscious breathing. So like I said, you can stop and think, all right, I am going to hold my breath. And you can do that. You can consciously control your breathing. But if you try to hold your breath too long, you faint. And then you're unconscious, or your automatic takes over. They have found an area in the pons that regulates the special times you're sleeping. So not when you're just sitting watching TV, but when you're actually asleep, or you're over breathing when you're exercising, or when you want to talk, like me when I'm talking to you guys, or when you're really emotional and you're just just really upset about things. And so we are able to trace that to the an area in the pons. But we also have located an area in newborns that your book doesn't talk about. But one of the scariest things, you've just given birth, you've got this precious, precious baby, and you want to protect it from everything in the world, and you want it to grow up and be an amazing person. And everybody has heard of sudden infant death syndrome, or SIDS. And this is where the baby just stops breathing. So you just put your baby to bed one night and it's all healthy and fine, and you think everything's great, and you go the next morning and the baby's passed away, and they check and they say, oh yeah, your baby just stopped breathing in the night. And so for the first year, children are at higher risk. And at one time they said, well, always put your baby on its stomach. Make your baby sleep on its stomach, and then that way if it vomits, it won't aspirate its vomit. It won't go, breathe the vomit back up into the lungs. And so, because little babies, if you don't burp them well, then they'll burp up. So a lot of times you put the baby down and it'll burp up. Well, nowadays, the thing is, if you lay your baby on its back, then it won't die of SIDS, or it has a less chance of dying of sudden infant death syndrome. So I just remember that my grandchildren did not want to sleep on their back. So the compromise was to kind of prop them up on their side in the corner of the crib and allow them to be that way. So they weren't on their stomach like they wanted to be, but but they weren't on their back. And it's interesting, this is so prevalent. I've actually seen babies with the back of their head flat because their parents make them sleep on their back all the time. So that's kind of an odd looking thing. The other thing is babies who are wanting to sleep on their stomach but are being forced to sleep on their back will toss their head back and forth, back and forth. And I've actually seen babies rub all the hair off the back of their head because they're trying so hard to flip over and get back over onto their stomach. But anyway, we actually have found an area in the brain that is defective in children who are going to experience sudden infant death syndrome. So that made me feel a whole lot better than they could actually detect it ahead of time. They give you a quick overview of the brain in case you've forgotten it. So there's the cerebellum and the cerebrum. Here's the cerebellum, and then there's the pons that they're talking about. I don't know what the current term is, but in my day we called it freaking out. So somebody would get really upset and they would start hyperventilating. And they would breathe so fast that they breathed out too much carbon dioxide. And as you lose your carbon dioxide, your pH rises, your blood becomes actually alkaline, and it causes your cerebral arteries to constrict. And you'll start getting dizzy, and you may even faint. So if you have somebody who's totally freaking out, what you can do is make them breathe into a paper bag. Of course, nowadays, trying to find a paper bag is kind of a hard thing to do, but you could have them breathe into a plastic bag as long as you don't put it over their head. And what this will do is as they exhale CO2 and then they rebreathe, they'll pull back in some of that carbon dioxide so that they don't change the pH of their blood too much. When we did the circulatory system, we talked about chemoreceptors in the carotid arteries and the aortic arch. And they respond to oxygen levels and carbon dioxide and the pH. And when you talk about CO2 and pH, you're kind of talking about the sort of the same thing there, because the CO2 dissolves into the plasma, creating carbonic acid. And then it can dissociate and release the hydrogen and make bicarbonate. A long time ago, I learned a little trick to help me fall asleep, but I didn't really understand it until I took a course like this. But you have stretch receptors in the smooth muscles of your bronchial tubes and the bronchioles and in your visceral pleura. Remember, the visceral is the layer that actually touches the lungs. So these stretch receptors, as you're breathing in and you're taking a deeper breath and a deeper breath and a deeper breath, you're going to stretch these receptors. And this is a protective reflex that will actually stop you and say, nope, you breathed in enough, let it out. So if you're laying there and you're having trouble sleeping, take the deepest breath you can. Do it slowly and fill your lungs as full as you can. And then let it out slowly. Don't push it out really hard, but just let it out until you've let all of it out that you can. And then continue pushing just a little bit more to get that last little bit of air out that you can. And then you draw in another breath, and you're doing this slowly. And you draw in another breath, and deeper, 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 and then you let it out. And I have found that I can't get past 4 of those without falling asleep. So part of it is you are interrupting your breathing cycle. But the biggest thing is whatever it is keeping you from sleeping. While you're busy doing those inhalations and exhalations, that's all you're thinking about. And the thing that was worrying you will just kind of slip away as you're taking those deep breaths and deep exhalations. So try it. Let me know if it works for you. But all the people I've told to, they say, oh my gosh, it works like a charm. Now I want to talk for a minute about sleep apnea. Sleep apnea is where you stop breathing as you go to sleep. And it's not uncommon for everybody to have some episodes of sleep apnea. If you reach a certain level, and it depends on which doctor you talk to, more than 10 an hour, more than 20 an hour, then they think you may need some help with your breathing at night, or you need to find out what the problem is that's causing you to do this. And if you've ever slept with someone who snores, you'll hear them snoring, and all of a sudden you don't hear them snore for a second. And it's silent, and you hear this kind of noise, and then they start snoring again. They just had an episode of apnea. So they were snoring, they stopped breathing altogether, and then that snorting noise is them starting back up, breathing again. So apnea is where your breath, you're not breathing for some reason. Now, some of the things that can cause it are bronchoconstriction. If you have all kinds of irritants in the room with you, somebody is smoking or there's smoke in the room, a dusty room during the pollen season, you maybe have pollen in your house that's causing you all kinds of problems. Cold air. Too much mucus. You got a cold. Something is clogging up your airways with mucus. All of these things can trigger bronchial constriction and shallower breathing, episodes of apnea, or coughing. So any of these things can happen. If you have someone you know who has apnea, look around and see, is there something you can do to get an irritant out of the room? I am dealing with a friend of mine who has sleep apnea, and he has cats. He's allergic to cats. So every time the cat comes into the room, he gets all the cat dander in his lungs, and he starts having apnea episodes, which is obviously not healthy. But, how do you give up a cat that you love? Well, there you are. But look and see, is there something causing the person's apnea? Now, sometimes it's just because you're older and you're fatter and you have a lot of extra tissue that causes your airway to collapse. So a lot of times they can go in with lasers or scalpels and remove some of the tissue to open up your airways so that you can breathe and you stop having apnea. But the other thing they can do is they can put you on a CPAP or a BiPAP, and it will actually help you inflate your lungs. It will push the air in with just a little more force. So you hopefully will get past whatever that is causing the constriction or the collapse of your airway and stop you having apnea. Because apnea, if you're holding your breath, you're not getting oxygen, and your oxygen levels will start dropping. So most people didn't even think about their oxygen levels until we started having all this COVID stuff going on. And now, they check you to see how much oxygen you have. And you have those little finger things that you put on, and it'll read what your heart rate is, and it will tell you how much oxygen you have in your bloodstream. And of course, you want to be around anywhere from 96 to 100. That would be a good thing. But people with apnea, can drop down to around 80, down to 60. And so that's no good. That's not nearly enough oxygen to keep your body going. So someone who's that severe with apnea is going to need a breathing apparatus of some sort. So this is a clearly staged picture of somebody wearing a BiPAP. But basically you cover up your nose. So you have this, it's going to pump air in through the tubing and in. And then it has a valve that allows you to exhale back out. So it monitors the pressure, it monitors how often you breathe. It has a little computer in there, and it sends the information to your doctor. When you sleep, you don't have control over the muscles around your mouth like that. So your mouth kind of hangs open limply, and you kind of drool a little bit. But anyway, it looks nice. Remembering when we talked about the heart, and here it is pointed off to the left, and there's the apex, and there's the base of it. And then you have the aorta coming out, and there's the aortic arch, and then it descends, and you have the descending aorta, which you can't see, and it branches off. Well, we never followed that when we were doing the circulatory system, but here they're showing it because it goes up. It's got to go up to the brain, then it's going to branch off and come to the rest of the body, obviously. And you have sensors up here in the carotid arteries, close to the brain. And while we don't know the mechanism of what makes you breathe or what sets the rhythm for your breath, we do know that there are some things that will influence your breathing. So this is showing you where they are. And then you have some aortic bodies in this arch right here. So they're going to send extra messages to the lungs to make them do something different than what's normal. I seem to hang out with a lot of nerds, and that's fine with me because I find that they have really interesting things to talk about. So we were talking about holding your breath until you passed out, and then your CO2 levels rise to the point where your automatic controls override your will. So you can't stop. You can't hold your breath till you die. However, this person was going, well, you can if you're underwater. Because if you think about underwater, so we've talked about air pressure and interpleural pressure. And if you don't understand what I'm talking about when I talk about the interpleural pressure, read in your book on page 843 because you got to know about the pressure. So we talked about going up to Machu Picchu or up to Denver where you have trouble breathing because there's not as much air, there's not as much pressure to force the air into your lungs and through and on into the capillaries where it needs to go. If you go down under the water, you have too much pressure. And so you not only will press the oxygen into your bloodstream, but you'll also press nitrogen into your bloodstream. And the pressure will actually cause you to dissolve so much CO2 that you can actually hold your breath until you die underwater. So, but I don't think anybody's going to go down underwater and hold their breath and say, I'm just going to hold my breath until I die. But another interesting thing is, you and I, if we go underwater and we hold our breath for a while, and then we're going to have to come up because we're going to have oxygen. So our body's going to say, come up, you need air. But there are people who have trained themselves to hold their breath for unbelievably lengths of time. And because they dive down and they find the shells that have pearls in them. So pearl divers can actually dive down for 6, 7, 8 minutes. Where you and I, there's no way. After a minute or two, we've drowned. Because if you don't get to the surface and breathe some air, you'll die. But they have trained their bodies because that's their livelihood. That's what they do for a living. Your book goes into the laws of physics that govern the volume of air and the pressure of air. And I don't care for you learning those or not learning them. I'm not going to be testing you over them. But if you look at them, they do it all with mathematical symbols and big words. And you're like, oh my gosh, I don't know if I can ever understand that. Well, basically they're telling you common sense stuff. So the flow of a fluid is inversely proportional to the resistance. Well, you can translate that into English and say, if you've got a little bitty garden hose and you're trying to get water through it, you're not going to get very much water through it. And if you've got a great big hose like the ones that the firemen have on their fire engines, then you can get a spray of water that is so strong that it'll actually lift you up off the ground if you're holding the tube that the fluid is coming through. So the flow of a fluid is inversely proportional to the resistance. So the smaller the tube, the less of the pressure you can get, simply because you don't have that big of a tube. So the resistance is the walls of the tube. All right, so that one's kind of like, yeah, I think I already knew that one. Boyle's law says at a constant temperature, the pressure of a given quantity of gas is inversely proportional to its volume. Well, let's blow up a balloon. Okay, see the size of the balloon? Now push air into it. So you have increased the pressure inside of the balloon by forcing air into it. And as you do that, the volume of the balloon increases. How about that? So what does inversely proportional mean? Well, according to this, the pressure is inversely proportional to the volume. So if you have more pressure, you're going to have less volume. Or if you've got more volume, you're going to have less pressure. And you stop and you think, no, wait a minute, that's not right. Because if I blow into the balloon, I'm increasing the pressure and I'm increasing the volume. So in order to use this particular law, you're going to have to seal off the balloon. So take your balloon and tie it off so you can't let air in or out. And now make the balloon get bigger. The pressure inside the balloon is going to go down because the air molecules have more room to spread out in. So they have less pressure. So that's one of the reasons that's really great for a physics class. And if you guys want to study it, by all means, there's YouTubes out there that'll show you how to do the Boyle's law, the Charles law, and all of the other laws. But they're trying to explain why your lungs inflate using physical laws that most of you have never studied before. Normally, when we're talking about pressure, we talk about millimeters of mercury. But when they started looking at the lungs, they're so fragile and the pressure is not as extreme as is, say, barometric pressure. So they switched over to using centimeters of water instead of millimeters of mercury. So water is more sensitive than mercury. So that's why they use columns of water. But of course, nowadays we don't use mercury or water. We have machines that measure. So if you want to find out how a person is breathing, what the pressure is, what their airflow is, things like that, you just hook them up to a machine and it measures the volume of the air and the pressure of the air and all of that, and how many respiration, how many times you breathe per minute, and it puts it all into a computer and prints it out in a nice little graph for you. So we've come a far way. They're talking a little bit more about what I was saying, how the lungs are riding up and down on the diaphragm, but it's also talking about those pleural layers, the layers, the double layer that's around the lungs, which we call the pleural cavity or the pleural sacs in the pleural cavity, and they are literally attached to the ribs by cohesion of water. So water, if you've ever put two glasses that were a little bit damp together, and then you try to pull the two glasses apart, or two plates that have gotten there wet, and you put the two together and you try to pull them apart, that water will hold them together. So with the sac being attached and pulling with the ribs, so you're inhaling, the ribs come out, the diaphragm goes down, and the lungs, because they are attached to the visceral pleura, and it's attached to the ribs by the parietal pleura, it pulls the lungs open that way too. So you don't just have the pulling down and the riding of the diaphragm, but you actually have the adhesion or cohesion of the water holding the lungs open, attached to the ribs as the ribs expand and contract. So here's Charles' law saying the volume of a gas is directly proportional to its absolute temperature. So we kind of know this. If you warm up a gas, then the volume expands. And if you get a gas cold enough, then it will contract. The gas will contract to the point where you can actually make liquid carbon dioxide. You can make liquid nitrogen. You probably heard of these things. So, and they're very, very cold. So their volume is very, very small and their temperature is very, very cold. So it's directly proportional, not inversely proportional. So if you're trying to breathe and it's cold outside, you're not going to be as able to breathe as well. So that's one of the nice things about having the structures in our nose. Remember the meatuses? Somebody's put a pipe cleaner in there to show you where the meatus is between the concha or the folds. So as the air comes in, it gets warmed up. And this helps with the exchange of gases. So using Charles' law, as you warm the air, as it goes into your lungs, the warmer it gets, the more it spreads out. And so you're able to inflate the lungs because the gases are spreading out because they're warming up. I always like to throw a weird video in every now and then to see if you're still awake. So here's a guy playing a trumpet. This is back before we knew that using x-rays for extended periods of time was dangerous. So look at the tongue. Also, look at the cavities or fillings. Here's the slide that spells out pneumothorax, which is a collapsed lung. And so they've split out pneumothorax is the air going into the pleural cavity causing the lungs to collapse, but the actual collapsed lungs is called an atelectasis. Atelectasis, sorry. I always want to leave that syllable out right there. Atelectasis. We're going to spend some time talking about restrictive problems that you can have with your air and obstructive problems you can have with your airways. So some of the things that have to do with resistance is the diameter of your bronchioles. So if you've got anaphylactic shock going on, if you have asthma, then you're going to have a narrowed airway. Obviously, if you have lung cancer in your bronchial tubes, you have a narrowed airway. So you're going to have resistance to the airflow. But usually they're talking about the diameter of your bronchioles is the resistance. Sometimes they're talking about the fact that your lungs are hardened and you really can't inflate them very well because you've replaced them with scar tissue. Cold air, obviously, it's going to cause you a little resistance to airflow. This slide talks about some of the things that can cause your bronchioles to increase in diameter. So epinephrine, which you and I call adrenaline, will do it. Sympathetic stimulation, you're under some strong emotion for flight or fight. Anytime you see the word sympathetic, just think, there's a bear coming. What are you going to do? And that'll kind of help you there. So you're going to increase the diameter of your bronchioles because you want more oxygen in there, because you're about to run or scream or something or fight. So you increase your airflow. If you are talking about bronchoconstriction or making the airway smaller, histamine will do that because it causes fluid to go into the tissues and it literally swells the lining. And this would be the opposite. This, instead of sympathetic, this is parasympathetic. So your parasympathetic nerves are usually talking to your airways and saying, okay, you don't need to be really big because everything's cool and we're not freaking out, and so we don't really need a whole lot of extra oxygen. Cold air can cause some people to have spasms in their bronchial tubes. And of course, any chemical irritants, smelling bad things, getting pollen in there, things like that, can cause your airways to close off. But I want to tell a story. I always tell stories. But hopefully it ties together some of the stuff that you're learning and puts it in your mind instead of just memorizing stuff like sympathetic versus parasympathetic. So anyway, my daughter was babysitting some little kids down the street, and she called me and she said, Mom, I think one of the kids isn't breathing. And I'm thinking, she's a kid and she's, kind of hysterical and whatever. I said, well, bring him on over and let's look at him. And so she brings the kid. She didn't put clothes on him, a coat or shoes or anything. She just grabbed him up and carried him out through the snow and over to the house. By the time that she got him from his house down the street into our house, he had been trying to suck in this cold, cold, cold air that was outside. And when she got him into the front door, he started to take a breath. And it was a whooping sound. It was just this big, I don't think I can make that noise for you to let you know what it was like. But he was just like, trying to get the air through and making this horrible just coughing noise and gasping for air. And I said, oh yes, okay, definitely we're going to call the parents, and the parents are going to come home and they're going to take the kid to the hospital. And so as it turned out, the kid had whooping cough. And I could tell that when the parents picked him up. I said, I think he's got whooping cough. And they just looked at me kind of funny, like, what? And when they got to the hospital, that's what happened. And the kid had stopped breathing, but when she took him out in the cold air, his body was still trying to suck in air. And because cold air is drier, it doesn't have the moisture in it, it helped him catch a few breaths and got him to where he could breathe again. But he had actually swollen shut to the point where he couldn't breathe. So one of the things that you vaccinate your children for is pertussis. DPT shot, is the P is pertussis, and that's the fancy name for whooping cough. And children die from whooping cough. So it's really important to get your kids vaccinated so that you don't have almost tragedy. And at the hospital, they said, had she not taken him outside into the cold and carried him over to my house, that he might very well have not made it. And of course, that just scares you more than you can even imagine. And it's interesting now, the kids are grown and they're all successful in their fields. And I think how close they came, the one of them, to passing away that night because of whooping cough. So I guess the take-home message there is, if you find someone who can't breathe, they are so obstructed that they are having trouble breathing for something like the whooping cough, if you could get them to stick their head in the freezer and breathe in the cold air, it might help while you're waiting for the paramedics to come. Here's the slide talking about resistance to airflow, that's talking about degenerative lung diseases where your lungs are stiffened by scar tissue. Sometimes you aren't making enough surfactant. Premature babies don't have the surfactant, so they have to use artificial. So these things all are resistance to airflow. There are a few things that you are required to know and understand. So I'm going to talk about them individually, and then I'm going to show you a really cool graph that puts everything together for you. But you all have seen the tide come in and go out in the ocean. The tide comes in, the tide goes out. Well, they name your breathing in and your breathing out your tidal volume. So if everything is normal and you're not doing anything special, the amount of air that you breathe in and you exhale is about a half a liter. It's about 500 milliliters. So if you can see a 2-liter pop bottle, Coke, whatever you drink, and look at a fourth of it, a fourth of a 2-liter bottle or half of a liter bottle. You have an inspiratory reserve volume that you can inhale with your maximum effort. So if you are trying to get the biggest amount of air that you possibly can, maybe because you're going to dive under the water, maybe because you're going to sing and try to hold a note for, 30 seconds or something, but you want to pull in as much air as you possibly can, then 3 liters is about how much you can do. That's 3,000 milliliters. So that would be 1.5 2-liter Coke bottles of air. So that's called your inspiratory reserve volume. So the hardest you can breathe in and expand your lungs, you can get 3 liters. And your expiratory reserve volume. So you breathed out, and now you want to breathe out the maximum amount that you possibly can. You can get out about 1,200 milliliters. So 1.5 liters, or 1.2 liters. So this is how they get those volumes. First of all, they have to pinch your nose shut so that you don't leak any air in or out through your nose. So they just want to see how much going through your trachea and down into your bronchial tubes and into your lungs, how much you can get in and how much you can get out. So this is spirometry, and you can see instead of pushing up liquid water or liquid mercury, that he's blowing into a machine. And so it's all digital in there that he's measuring it. And this is kind of a tracing that you're going to get. So we're going to break this down. We're going to talk about each of the things that are in this picture. So spend some time with this picture. If you want, after I finish talking about it, pause the tape and look and see if you can figure out what each of the things are. So here's a person just breathing normally, up, down, like this. And this, you notice, is from 2,500 to 3,000. So that's 500 milliliters, or half of a liter, for tidal volume. So this is called tidal volume. There you go. And they make that the yellow right there for the tidal volume. Now, from here to here is your total lung capacity. So from completely empty to as full as you can get it without actually damaging the lungs is your total lung capacity. And that's around 6 liters. Now, obviously, for a little kid, this is going to be different. For a little woman, it's going to be different. For a great big old 6-foot-something guy, it's going to be different. But on average, it's about 6 liters. Or 6,000 milliliters. All right, so you have this area down here, which is the light blue, which is the residual volume. This is the amount you have in your lungs. You cannot exhale. You cannot exhale. The only way you could do it is to collapse your lung completely. So even pushing out as much air as you possibly can, you're still going to have a little over 1,000 milliliters. You're going to have over a liter of air that remains in your lungs at all times because your lungs do not collapse normally when you breathe. So it would take an actual somebody stabbing you or a rib breaking and puncturing your lungs to cause the lung to actually let out this last little bit of residual volume. So residual is what's left over. All right. So from here, which is your tidal, see, we're breathing normally, breathing. And then they say, okay, breathe out all you can. Okay, so this is your expiratory reserve volume. So this is what you normally do, but here's where I want to just breathe out as much as I possibly can. So I'm going to have to use different muscles, and I'm going to have to override my autonomic system that's normally telling me what to do. And I'm going to take control and say, okay, I'm going to get rid of all that extra air. So that's your expiratory reserve. And then, of course, if you have an expiratory reserve, you have to have an inspiratory reserve, and here it is in pink or purple, whatever that color is right there. So you go from 3,000 to 6,000 that you can breathe in. So normally you're taking in about half a liter, and then all of a sudden here you're like, no, I'm going to take in a whole lot more. So instead of half a liter, I'm going to take in an extra 3,000 milliliters, or an extra 3 liters, because I really want a deep breath. So this is measurement. Now they let the person do tidal again. They have them do it again. They have them do it. So this is checking all of these different things. From here, the dark blue, through the yellow, through the pinkish purplish color, that is called your vital capacity. That is how much air your lungs can inhale and exhale if you're really trying. Now remember, you can't get that last little bit of residual volume. So the residual volume is not part of your vital capacity or your living. Vital is your life. So this is your vital capacity. So that's a little bit, it's about what? If you take 1,000, 200 or 300 away from 6,000, that's your vital capacity. And then your inspiratory capacity is from here all the way up to there. So your inspiratory reserve is the extra reserve. You've reserved it. I got it there if I need it. It's in reserve, but I'm not using it normally. So your inspiratory capacity is what you normally would breathe plus the extra that you have, the inspiratory reserve volume. So if you add those two together, the lung capacity and the inspiratory reserve volume, you get the inspiratory capacity. So you can play around with this and figure out your functional residual capacity is how much extra you could breathe out, except for remember, this reserve you can breathe out. The residual, unless you puncture the lung, you're not going to be able to. So the functional residual capacity is not as useful as the expiratory reserve volume is. Because you notice the kid breathing, he didn't come down in here. He didn't die. Nobody stabbed him. So, like I said, you might want to stop now and go back over tidal versus expiratory reserve, inspiratory reserve, inspiratory capacity, functional residual capacity, total lung capacity. So there's some of the things that you kind of need to know, and hopefully you learn something like that in lab too. If you look at this slide, it just looks like a bunch of math, and so I think the graph does a whole lot better than looking at these formulas. But vital capacity would be the expiratory reserve volume, and the TV, tidal volume, and the inspiratory reserve volume which is about 4,700. So remember, we got 1,300 that you can't exhale. So if you took the vital capacity and subtracted, or excuse me, added on the residual volume, you get the total capacity, the total amount that you could hold, which would be 6 liters. So 1,300 plus 4,700 is the 6,000. So it looks like a bunch of math and it looks like a bunch of abbreviations, but if you go back and forth with the graph, then you're like, okay, I got it. So the functional residual capacity is the, get it over here, residual volume here, plus the expiratory reserve volume, ERV. There you go. And it's approximately 2,500 milliliters. And the reason this is important is after you normally breathe, I'm doing tidal breathing. I'm not exercising. I'm not doing anything weird. I'm going to have 2,500 milliliters of air that remains in my lungs after I exhale. So, because I'm not going to use this, because that's when I push the air out, and I'm definitely not going to use this because I haven't been stabbed. So this amount right here remains in your lungs. And what's important about that is I'm not even breathing at this point in time. I'm exhaling, but because that air is behind, I'm still passing oxygen across and I'm still passing carbon dioxide across. So that's important. You don't just exchange gases when you inhale and then stop when you exhale and then start again. You're constantly passing the gases through. So that's one of the things that they're pointing out here. Although if you look at that, you're like, I don't even know what the heck they're talking about. But it's the amount of air remaining in your lungs after you've exhaled, that you're still doing gas exchange. Now I'm going to stop here for just a second and talk to you a little bit about why CPR works. So, you know, I'm just kind of wicked, mean, and evil sometimes. And I worked for the military for many years, and I was stationed overseas. And one of the things that they did for us that was kind of cool is they paid for us to take CPR classes. And so, you know, being a smart aleck, I just raised my hand and I said, so what value is it for us to breathe into somebody's mouth our carbon dioxide? I mean, why would you want to put your mouth on somebody's mouth and blow carbon dioxide in their lungs? Because they're already not breathing, and then you just give them your carbon dioxide. Well, I knew the answer, but I was just wanting to see if anybody else in the audience had actually ever thought about that sort of thing, and also to see how good the teacher was, because I was going to have to spend all day with this person. Well, the air around you is about 80% nitrogen, which your body can't use in the form of a gas, and about 20% oxygen. And if you add those together, 80% nitrogen, 20% oxygen, then you're like, well, wait a minute, that's almost 100%. So where's the carbon dioxide in all this? Well, the carbon dioxide is 0.04%. 0.04%. So it is so very, very, very little. It's surprisingly little. So when you are breathing in air, you are putting your carbon dioxide into the air and then you blow it into that person's lungs, but it's still 20% oxygen. So you're going to be pushing a lot of oxygen in there and just a little teeny tiny bit of carbon dioxide that you're going to be blowing into their lungs. So feel free to do CPR. But it did strike a lot of people like, yeah, why would you want to blow carbon dioxide in people's lungs? Wow, that doesn't make any sense. And now you know. before I left to work with the military, I taught in the coal fields. And one of the things that I noticed was that the coal miners hate to wear the mask and the breathing apparatus that filters out coal dust. And as a result, they fill their lungs up with coal dust. And the name for that condition, where you've got literally particles of coal down in your alveoli, blocking your ability to breathe, that's called black lung disease. And truly, your lungs are black. You know, once you pass away and they cut your lungs out, so many of your alveoli are full of that coal dust. And in Kentucky, I know that if you have been in the coal mines, if you've worked in the coal mines for over 10 years, they just automatically assume that you have black lung. Because, like I said, they won't wear the breathing apparatus that blocks out or filters out the coal particles. So I always thought that was odd. But now that we're in a time where we have to wear masks all the time, I have a little more sympathy with them, because I would hate to spend my whole life underground trying to breathe in the coal dust around a respirator or a mask. Tuberculosis is another thing that's going to limit the amount to which you can inflate your lungs. So if your lungs are full of coal dust, or if your lungs are full of walled off bacterial infections. So the tuberculosis gets its name because it makes little tubercles inside your lungs. So if you look at an x-ray, you can actually see the walled off areas of tuberculosis. So here's one picture of somebody with tuberculosis, and this is actually a section showing the masses or the tubercles of tuberculosis in their lungs. This is what it would look like if you were looking at it under x-rays, and you can actually see the tuberculosis in the lungs, the little knots of infection. In the last chapter, we talked about type 4 hypersensitivity, which is a delayed reaction to something that you're mounting an immune response to. So if they do it correctly, they'll take a little bit of the inactive tuberculosis. You don't want to inject somebody with active tuberculosis, and you just inject it just barely under the skin to where you actually make a little bubble, so you can actually see it raised. So instead of sticking the needle down, you just kind of want to slide it under the skin just slightly and then release the fluid to make this bubble. And then you come back and check it in a day or two and see if it turned red. And if it did, then that means that you have been exposed to tuberculosis, or you have tuberculosis at this time. So that's what this means. So if you've got antibodies to tuberculosis, then you're going to get a positive result. A person who does not have tuberculosis, the fluid will be absorbed into the skin, and this little blister will go away instead of remain puffed up and turn bright red. So this is a positive tuberculosis test right here. So those were examples of restrictive problems that you can have in your lungs. Now there are obstructive disorders. If you have asthma and your airways close off, or whooping cough where your airways close off, or if you have chronic bronchitis, itis means inflammation. So you chronically have bronchitis. You've got, usually it's a bacterial infection. It could be fungal, it could be viral, but it's generally, more often than not, it's going to be bacteria. So it causes your airways to literally swell shut. And if you have emphysema, you have a little bit of both, because you're actually destroying the alveoli and turning them into scar tissue, so you have less able to move lungs because you replace the soft squamous epithelium with scar tissue, and it's also obstructive. So emphysema gives you a little bit of both. And most people know somebody who's got COPD, chronic obstructive pulmonary disease. And COPD, there's over 3 million cases in the U.S., very common. There is no cure, but there are treatments that you can do. And this is one of the things where you'd have a whole series of tests. They would do the spirometry on you, and they would do imaging and things. It is common for 40 or older, and females, oddly enough, are more likely to get it. And if you have a family history of COPD, then your chances are much higher. So the symptoms would be shortness of breath. You have trouble getting your breath. A chronic cough. You just cough nonstop, and wheezing. So when you go to the doctor and they listen to you, they put their stethoscope on the back of you. This is one of the things they're listening for, to see if you have wheezing or rales, noises inside of your lungs. So the air sacs start breaking down, and so instead of the nice little grape sacs like they're supposed to be, you have more of a smoothed out area. And then your airways are full of mucus. So chronic obstructive pulmonary disease. So when we looked at the tracing of that boy and looked at his tidal volume and his inspiratory reserve volumes and his expiratory reserve volumes, one of the things that they didn't do on that particular graph was to show us what it looks like if you have an obstructive respiratory problem or a restrictive respiratory problem. So imagine that your airways are blocked with mucus and your alveoli are compromised. They're being replaced by scar tissue, or they're filling up with particles. You could also get silicosis. You can get sand. People who work in construction sometimes get sand in their lungs. And so this is also not a very good thing. And of course, you've probably heard of asbestos getting in the lungs and causing mesothelioma. So one of the things they're going to make you do is push your air out as fast as you can and pull your air in as fast as you can. And that's going to tell you if there's some sort of a problem, because we know how long it takes healthy people to get out their air and to pull in their air. But obviously, if you're constricted, or if you have mucus in there or whatever, you're not going to be able to inhale and exhale as fast as a normal person. So they're also looking at the actual amount that can be exhaled in a given period of time. I was trying to find my picture of a white blood cell eating asbestos, and instead I ran across this cool video that I forgot to show you. So this is your diaphragm and shows you breathing. You can actually see the diaphragm moving up. You can see the lungs getting smaller. Let's do that again. See the ribs coming out? The shoulders move also. And this is going into if you intubate someone. So you can actually see the rings right there. And then you can see where you can go off into the trachea, or you can go down into the esophagus. So you actually can choose which way you go. Isn't that neat? I'm still looking for my picture of asbestos to show you, but I ran across this one. And this is a tie-in between last chapter and this one. We talked about the major histocompatibility complexes, and one of the sexiest men was James Dean. And so this was a clipping that I found showing James Dean and how the women, because he was a bad guy, but they said the major histocompatibility complexes cause an odor. And since we're doing the respiratory system, and part of what the respiratory system does is pick up odors, it's a nice tie-in from the other chapter. Finally found the picture I was looking for. This is a white blood cell. So you remember you have those dust cells or the alveolar macrophages that are in your lungs. If you breathe in asbestos that is of a certain size, so if it's little bitty, it's not a problem. If it's really big, it's not a problem. But if it happens to be slightly bigger than a white blood cell, this is what happens. Here's a white blood cell eating asbestos fibers. So here's some, and clearly it tries to engulf it, it tries to wrap around it, but what happens is the asbestos actually pokes a hole in the macrophage, causing the contents to leak out. And if you remember, what white blood cells do when they're dying is they release all kinds of chemicals that summon other white blood cells. They release cytokines, all sorts of things. So the dying cell summons more to the area, and then they try to eat the piece of asbestos, and they're no more successful than this one was, and so then they die, and then you get a constant irritation in this area, because white blood cells don't die easily. They take out nearby cells too. So if this asbestos got sucked into your lungs, these death cells are going to go over and over and over trying to kill it. And they're going to kill more and more of the cells around where the asbestos fiber is. And eventually what's going to happen is you're going to develop a mesotheliomal kind of cancer. And asbestos is the only one that causes mesothelioma. So if you hear the doctor say that, you know at some point you were exposed to it. So if asbestos is in sheets, like they used to put it in everything because it's fireproof. So they made the floor tiles out of it. They made ceiling tiles out of it. They put it in the walls. And it's when you try to take the asbestos out that you start breaking up the fibers into smaller pieces and smaller pieces. And if you don't capture all of those smaller pieces and someone comes along and breathes in just the right size, then it can trigger lung cancer, specifically due to asbestos. I was looking back over my notes to see if there were any concepts that I left out that I meant to cover. And one of them, we were talking about the obstructive and the restrictive problems that you have with breathing. In like tuberculosis and black lung, where you've got the lungs full of stuff, or you replace it with scar tissue, the thoracic cavity itself continues to expand normally. It's just that your lungs can't expand because they're no longer elastic. They're scar tissue. So that was one of the things I wanted to point out. And when we were talking about how the gases exchange and how they dissolve in the surfactant and stuff like that, I wanted to give you an example that you're familiar with. So if you think about carbon dioxide under pressure, you think about your Coke or your Pepsi or Mountain Dew, whatever fizzy drink that you drink out of a can or bottle, and you open it up. So the first thing you do is you hear this hiss because there was more pressure in the bottle than there was outside in the atmosphere. So you're going to have this rush of air. And actually, if you are breathing it in as it's rushing out of the can, it'll make you cough because you're getting carbon dioxide. So if you leave the Coke open or the cola open, what's going to happen is there's more carbon dioxide compressed in that cola than there is in the air outside. So you're going to have diffusion from high concentration to low concentration, and your carbon dioxide is going to come out of your Coke, and your Coke is going to go flat. The carbon dioxide, as it leaves behind the syrup. So if you've tasted a Coke while it is carbonated, you get that acidic taste and the sweet taste, all that going on. But once the carbon dioxide has outgassed, because it's followed the diffusion gradient, then when you drink the Coke, it tastes literally like syrup. And you're like, ew, this Coke is flat. I'm not going to drink it. But if you could take some carbon dioxide and push it back into the cola, it would taste just like it did when you opened it for the first time. So it's just the loss of the carbon dioxide. So if you're having more carbon dioxide inside the capillaries that are on the outside of the alveolar sacs, then it's going to push the carbon dioxide through the two squamous cells with that basement membrane in between them, and the carbon dioxide is going to end up on the alveolar side so that it can be exhaled, so you can get rid of it. So if you can see the whole thing with the can of Coke and opening it up to relieve the pressure and the carbon dioxide rushing out, you kind of get a feel for what's going on when you inhale and you exhale. Just because I knew you were going to ask, hiccups are spasms of the diaphragm. So if your carbon dioxide level drops to a certain low level, and there's actually a clinical paper that you can read that will tell you exactly about it, then it causes these spasms of the diaphragm. So if you hold your breath or breathe into a paper bag, you're going to raise your carbon dioxide level, and it's going to stop the spasming of the diaphragms. And when your diaphragm spasms, it also causes the larynx and the vocal cords to close suddenly, which is that sound that you make when you have the hiccups. So I knew you were dying to ask, and since this is not a face-to-face class, you couldn't ask that question. So I rounded off the nitrogen to about 80%, the oxygen to about 20%, and there's a carbon dioxide at 0.04%. And the temperature will change that a little bit, how much water vapor you have. And then you have all these other gases that you know that are in the air, like helium and neon and argon and ozone. And they make up less than a percent. They're such a tiny amount. So nitrogen and oxygen are almost entirely what you're breathing in. And here's another one of those slides that kind of makes you think that your head's going to explode when you look at it. But basically, Dalton's law says if you take the pressure that is exerted by nitrogen and the pressure that is exerted by oxygen and water and carbon dioxide, and you add those together, you end up with 760 millimeters of mercury. So when you talk about at sea level, you're talking about the pressure in the air of all the gases combined is 760 millimeters of mercury. If you go higher, if you go up to the top of a mountain, then you're not going to have as much oxygen, you're not going to have as much nitrogen. The air is thinner as you go further up till you reach a point where there isn't any air. And then, of course, you have to wear a spacesuit or something to go up that high. If you go lower, if you go below the ocean, you dive down below sea level, then you're going to have much more pressure. So you're going to have some way to neutralize that in your body. And there's something called a nitrogen narcosis or the bins. There used to be a TV show, and this guy would always rescue somebody underwater every single week in the episode. And then he would always come up too fast because he ran out of air because he was doing things. And then he always had the bends. So they had to have a hyperbaric chamber, and they had to force the nitrogen back into his body and then slowly release it. Because if you go down deep, you're going to be pushing nitrogen into your bloodstream that should not be there. So you're going to be pushing all these gases into your bloodstream, but since about 80% of it is nitrogen, that's the one that they blame. So if you come up too quickly, then the little bubbles of nitrogen that built up in your bloodstream will get larger and larger. They'll expand because you don't have the pressure on them anymore. And it causes severe cramping, severe pain, and so they have to put you in the hyperbaric pressure and put a lot of pressure back on you, and then slowly let you decompress or slowly let the nitrogen out of your body. Here's the slide that tells you that the CO2 and the oxygen swapping across the respiratory membrane, which is the alveolar squamous epithelial cells on one side and the squamous capillary cells on the other side. There's the liquid inside the capillary, obviously the plasma, and then you've got the surfactant in the lungs. So you have liquid, so the oxygen and the CO2 are actually passing from liquid to liquid. So for oxygen to get into the blood, it has to dissolve in the water, pass through the respiratory membrane, and then come on out that way. And for carbon dioxide to leave the blood, it has to pass the other way and then diffuse out of the water into the alveoli. So you've got the oxygen going into the capillaries, and you got the carbon dioxide coming out, and it requires water. They have to actually dissolve and pass through that way. So that's why I gave you the analogy of the fizzing Coke. And now I'd like to speak briefly about Henry's law and partial pressures. Basically, gases diffuse down a gradient, we know from a high concentration to a low concentration, until the partial pressure of each gas in the air is equal to the partial pressure in water. Now, the one thing that Henry's law doesn't take into account is the temperature of the water. So there's another physics law that deals with temperature. So when I was looking at this and thinking about this, I was thinking about, is the climate change that we're seeing, the crazy weather, the extreme high temperatures, extreme low temperatures, the storms, volcanic eruptions, all the crazy stuff that seems to be going on with the world that they used to call global warming. But then when they realized, well, that didn't quite fit because we're actually having some record lows also as well as record highs. So then they just said, well, we're just going to call it climate change, and we're going to blame it on carbon dioxide. And I thought, well, when you consider that the majority of the earth is covered in water, and carbon dioxide is dissolved in the water, and it is dissolved in the air, and we know that we have an equilibrium going on, the question becomes, did the amount of carbon dioxide, which used to be about 0.025, rise to about 0.038 because the water got warmer and more carbon dioxide came out into the atmosphere? Or somehow is the carbon dioxide going up causing the oceans to warm? So I was talking about that to some of my students one time, and a parent Kid went home and told the parent, and the parent offered to come and beat me to a pulp. And I was like, alrighty then, okay. So, on the positive side, if we do clean up the atmosphere, if we do stop polluting, if we do all those things, then that will be a marvelous, marvelous thing. But if the slight rise in carbon dioxide from 0.025% to 0.038% was caused by the oceans warming, then maybe we need to look for another reason that the oceans are warming. Anyway, just saying, but don't send your parent to beat me up. Just look at Henry's Law and think about the outgassing of your Coke and the carbon dioxide going out of your Coke and into the air, and see if it's a possibility that the elevated carbon dioxide is not what's causing the warming, but the warming is what's causing the carbon dioxide to come up out of the water and into the air. In this slide, they're talking about carbon dioxide being 20 times more soluble than water. So you're able to diffuse the carbon dioxide much more quickly, even though it's at a much, much lower concentration than the oxygen is. And if you have emphysema, lung cancer, or tuberculosis, to name some of the problems, you have a decreased surface area. So you've actually destroyed some of your alveoli, and so you don't have as much place for the oxygen and carbon dioxide to exchange. Sometimes it helps to actually look at the tissue and kind of get a feel for it. So this is what the squamous epithelial cells look like under the microscope. So if I were to take a section out of your lungs and look at it, a biopsy, this is what it should look like, because hopefully you're all normal. And if you have pneumonia, then look how thickened. You have this swelling in this area because of the histamine release. So many of the people who are getting COVID are actually going on and developing pneumonia and dying. And you can see kind of why that would be, because this obviously is not going to be able to exchange gases nearly as well as this is right here. And then this is what emphysema looks like. And you notice that, look at all of the cells here, and look how few cells there are here that are left. So you slowly smother to death with emphysema. You can't get air through. And so what they have to do with people who have emphysema is give them enriched air. So instead of being 20% oxygen, 80% nitrogen, then they run it up all the way up. It can go up to 100% oxygen. If you and I breathe 100% oxygen in, it would kill us. We couldn't tolerate it. But if your lungs are destroyed by emphysema, so a lot of people go, well, I'm going to smoke and I may die of lung cancer, and so, but if you have emphysema, I've watched people linger for years and years and years and years, and they have no energy, they can't get oxygen, they can't think very clearly, and they're dragging this big old tank of oxygen around with them in order to breathe with what little bit of alveoli they have left. So there are some things worse than dying of lung cancer, and I would say that emphysema would be one of them that would be pretty horrific. So again, I sound like an old lady preaching at you, and that's exactly what I am. I don't care if you memorize the exact numbers that are on this particular slide, but of the oxygen that's going around in your body, about almost all of it is bound to the hemoglobin. You have a little bit that's dissolved in the plasma, but most of it's on the hemoglobin, and it's going to jump off the hemoglobin and go across In the opposite, carbon dioxide is almost all dissolved in the water. So it's forming carbonic acid in your water, in your plasma. There's about 5% that's bound to other proteins, and there's about 5% that's dissolved as a gas. So they're almost opposite. Carbon dioxide is almost all dissolved. Oxygen is carried as oxygen bound to the iron on the hemoglobin. I don't know if you guys had chemistry, but oxygen never runs around as a single molecule. You always have two oxygens running around together, which is why you see O2 written this way. O2. So that's a double oxygen. There's two molecules there. And if you look at hemoglobin, it has 4 hemes, and at the heart of each one of the hemes is an iron molecule, and the oxygen likes to stick to the iron molecule. So for every molecule of hemoglobin, you can carry 8 oxygens. So you can carry 1 O2 on one of the irons, 1 O2 on one of the irons, and if you multiply 4 by 2, you end up with 8. So this is the formula that tells you what's going on with the carbon dioxide. Carbon dioxide, which is CO2. I just saw that. The 2 should be down here. Whoever was typing put it up in the air. Anyway, so and plus H2O, so you got water, carbon dioxide dissolving in it, and you end up with carbonic acid. And it is in equilibrium with bicarbonate. So if you see, you take one of those hydrogens off, see H2CO3, HCO3. When that hydrogen comes off, now have bicarbonate. So a lot of times, if you have indigestion, you'll take some bicarbonate. My father used to drink a Pepsi. He swore that stopped his heartburn. So maybe it did. This is called a buffering system. So if I need my blood to be a little more acidic, I'm going to leave my carbon dioxide in this form. If I need it to be more basic, I'm going to put it in this form. So you're constantly adjusting the pH of your blood with the carbon dioxide. The reason I even go into this with you at all, it is to let you know that the carbon dioxide is not competing with the oxygen for that site on the hemoglobin. It's not like which one's going to get there first and which one is going to stick onto the iron. It's going to have the oxygen attached there, and the carbon dioxide is mostly just going to stay dissolved in the plasma. So, but there is another form of carbon and oxygen called carbon monoxide. So carbon dioxide is CO2. There's the 2 down where it's supposed to be. So the CO2 is not competing with oxygen, but carbon monoxide, which only has 1 oxygen, it's just CO. It loves the oxygen. The oxygen binding site on hemoglobin, and it will actually go and stick onto the iron, and not only stick onto it, but it's something like 250 times more sticky than the oxygen is. So given a choice, the carbon monoxide is going to stick onto the heme and not the oxygen. So then when it goes to the lungs, where it should be dropped off, it isn't. It isn't. You can't get it off. So you've saturated your hemoglobin with carbon monoxide. And if you saturate enough of your hemoglobin with carbon monoxide, now you can't carry oxygen enough to sustain life. So a lot of times, in times like this, where we have the snowstorm outside and people are like, oh, it's too cold and my car is too, needs to warm up. And so they go out and start their car and leave it in the closed garage because they want to keep it warm. They don't want to get the cold air and the snow and everything in the garage. And what happens is carbon monoxide builds up in the garage. And so people get in the car, if they sit in the car and they're texting or whatever, with the car running inside of a closed garage, sometimes they wake up dead. They end up dead because you just kind of fall asleep. Apparently, it's a very peaceful way to die. So I don't recommend it, but make sure that you ventilate your car if you're going to sit in it in a closed garage. Lift the garage door a little bit, at least, and let some of that carbon monoxide go out. Now, back to my rant on smoking. People who smoke have up to 10% of their blood full of carbon monoxide because they're inhaling the smoke. They're deliberately forcing it into the lungs, and it goes across, and the carbon monoxide sticks on the hemoglobin. So just something to think about when you're inhaling smoke, not only from cigarettes, but from other things you might be smoking. Another place you can get carbon monoxide besides cigarette smoke and engine exhaust is if you have an unvented heater, like a kerosene heater. I told you I spent some time overseas, and one of the things that they do in places like Japan, where you don't have heat in your house, is they'll issue you a kerosene heater and you carry it from room to room. So whichever room you want to be warm, that's where you light your kerosene heater. And they tell you, do not leave it on more than 3 hours. And a lot of people will say, well, that's silly. I don't want to be warm for 3 hours. I want to be warm all night long. So I'm just going to hit it again and do it another 3 hours. And they found a lot of people dead because they got carbon monoxide poisoning. So because those things aren't vented. So gas furnaces, if you have a crack in your gas furnace, the carbon monoxide can be blown back up into your house instead of being vented to the outside. So you want to have your furnaces inspected periodically to make sure that they're not leaking carbon monoxide in your house. And of course, you can put a carbon monoxide detector, kind of like the ones you put up for smoke detection. You can also put one up for carbon monoxide poisoning. So it doesn't smell. You don't know it's there. You just turn beet red. So it's going to compete for those oxygen sites. And I said 250, your slide says 210. And for people who don't smoke, less than 1.5% of all of their hemoglobin is tied up with carbon monoxide. So you're going to get carbon monoxide. If you're out in your car and you're sitting behind another car that's idling at a stoplight, you're going to get a nose full of carbon monoxide. So we're exposed to it all the time. But people who smoke can get up to 10%. If you get the atmosphere more than 0.2, now remember our atmosphere is 0.04. It's actually 0.038, I think, but they rounded off to 0.04. So if you got up to 0.2%, the CO is quickly lethal. So it doesn't take a whole lot of carbon monoxide to kill you. There's a whole series of slides talking about a chloride shift and talking about the dissociation and things like that. I don't think that that's something that you need to memorize. If you're going into pulmonary nursing or something like that, then by all means go through and read that and make sure that you understand it. I definitely am not going to ask you this sort of stuff on the test. I am going to talk a little bit about this slide. This is number 135. And red blood cells produce this compound, which helps bind to the hemoglobin, which causes the oxygen to be unloaded. So what I want you to know is there are things that will help you with your oxygen unloading if you're running a fever. So if you're needing oxygen in your body to keep your brain going, to keep all of the things in your body going that require oxygen to make ATP energy, all of that, you sometimes will run a fever. And a lot of people say, oh my gosh, I've got a fever. I've got to take something. I'm going to take some aspirin. I'm going to take some Tylenol. I got to knock this fever out. And you're actually slowing the progress of your getting better. You're prolonging your disease by knocking out the fever. So unless your temperature goes up to like 104, 105, leave it alone. It's actually doing something for you. Now, thyroid hormone also helps with the oxygen. So people who are deficient in thyroid hormone, they're hypothyroid, are going to have problems with their oxygen. They're also going to have a lot of problems with their mental problems, and without treatment, it can lead to death. If a baby is born and it's not making thyroid hormone, then its brain won't develop, and it causes a condition called cretinism, where there's no brain there. There's no functioning. You're not going to be teaching this child to potty train or to feed themselves or any of those things. So thyroid hormone is really, really important, and you should probably be tested for it, especially if you're bruising, and we'll talk more about that in the next chapter when we do the immune system. But thyroxine, or the thyroid hormone, is important for unloading your oxygen, getting your oxygen to the places that need it. Growth hormone is another one we're going to talk about when we do the endocrine system, and testosterone. Now, one of the things that old people have almost no testosterone, and old people have almost no growth hormone. And a lot of the old people I know are on thyroid replacement too. So as your body stops making these things, then you're going to have more trouble with your oxygen. And of course, adrenaline, if you're scared, you're going to get more oxygen unloaded, which is good because, again, you need to make a decision about whether to fight or flight. So adrenaline, epinephrine, all of these are going to increase your oxygen unloading. So my question is, why don't we give older people replacement growth hormone, and why don't we give older people replacement testosterone, and for that matter, estrogen? So that's been one of the things that I'm on my soapbox about, because, well, anyway, we'll talk about that when we do the hormone system, the endocrine system. This is just a graphical representation showing you at lower temperatures, you're not going to get as much oxygen to come off. And as you increase the temperature, you're going to get more and more oxygen that's released. So 38 degrees Celsius is normal body temperature for humans. 43, that's not even normal. The person would be dead. And obviously at 10 degrees, that would be way too cold, and you would also be dead. But they're just showing you, if you take the blood out, the hemoglobin out, and play with it with the oxygen, that these are the kind of curves you get. So the warmer you are, the more oxygen will be released. And like I said, with the oceans, the warmer the waters get, the more carbon dioxide is going to outgas into the atmosphere. So you get these curves for carbon dioxide or partial pressure for any gases. I'm showing you this graph to show you if you get more towards the acidic blood, you're going to get more of the oxygen released. And if you have a higher pH, you're going to get less of the oxygen that will come off of the hemoglobin and be available for you. So important sentence in the next slide is the most potent stimulus for breathing is the pH. So remember, when you breathe, you're not only bringing in oxygen, that's what we think about, but you're getting rid of carbon dioxide. So you're changing the pH of your blood by exhaling carbon dioxide, which then takes the carbonic acid out of your blood. So pH, so we have sensors that detect pH throughout the body and will regulate your breathing that way. And then we have sensors that look at carbon dioxide. So it's important also. And least significant is oxygen. So I thought that was kind of interesting. Here are 4 terms that you should know. So if you probably heard about acidosis, and you say, oh my goodness, this person is diabetic and they're having an event. They're talking about the acid in the blood. So if your blood pH drops below 7.35, we say that you are having an acidosis crisis. And if you go over 7.45, you have an alkalosis. So acid and alkaline. Acid, alkaline. Look at how close these are, 7.35, 7.45. That is so tight. So homeostasis, what's normal, is a very tight range, very, very small range. Hypocapnia has to do with hypo is not enough. And so if your carbon dioxide level drops below 37, then we say you have hypocapnia. And if you're over 43, then we say you have hypercapnia. So you have a little bit more of a range there that you can tolerate with the CO2 than you can with the pH. So remember, if they say that you have acidosis, it means that your blood pH is too low, dangerously low. And alkalosis is it is too high. It is too alkaline. It's too basic. And then capnia is the word for carbon dioxide. Capnia. So hypo, not enough. Hyper, too much. Hypercapnia, having too much CO2, is the most common cause of acidosis. So that kind of makes sense. If you have too much CO2, it's going to be dissolved in the bloodstream, and it's going to cause you to have carbonic acid. And if you have carbonic acid, you are in acidosis because your pH drops. So the pH and the carbon dioxide are completely dependent on each other. Sometimes students ask, is it dangerous to drink too much pop? Because Coke and all of those fizzy drinks are carbonic acid, and so they're going to lower your pH quite a bit when you drink it. But when you consider what causes it to be acidic, it's the carbon dioxide. So usually if you're drinking a Coke, watch, the first drink of the Coke or fizzy whatever you're drinking will cause you to burp. You'll either hiccup or you'll burp because the CO2 is leaving your body. You have too much CO2. They talk about respiratory acidosis and respiratory alkalosis if you are hyperventilating or not breathing enough. So you can drink things that have CO2 in it, but generally the problems you're going to have with CO2 have to do with your breathing and not being able to breathe out enough or breathing out too much, which then will make your blood become extremely alkaline. Another form of acidosis is ketoacidosis, And this is where you lose fat rapidly, and part of the fat forms acidic ketone bodies, and it's found in diabetics a lot of times. It's also a new fad that people are going on keto diets, and they deliberately throw themselves into ketoacidosis so that they'll break down the fat in their body. And I'm thinking, what will people think of next? Sometimes you see diabetics doing this weird breathing thing. They're hyperventilating, and they actually have a name for it when they're breathing in that way. They're trying to compensate for how acid that their blood is becoming by getting rid of carbon dioxide. So if you hyperventilate, you're blowing out your carbon dioxide as fast as you can. So it sounds really weird when you hear a diabetic go into this kind of breathing, but you know to test them and see what's going on when they start breathing funny. This slide kind of summarizes some of the stuff we were talking about. If you're less than 60 millimeters of mercury, that is not okay. And you're hypoxic, this can happen in people who have emphysema, pneumonia, or if you're at a high elevation where you just not getting enough oxygen. So the amount of oxygen in your bloodstream is not high enough. If you get not enough oxygen in your bloodstream, a lot of times you'll turn blue. And they call that cyanosis. One of the interesting stories about cyanosis and blue people is when someone from the hills of eastern Kentucky rushed a lady up to the UK hospital in Lexington. And one of the things that people in the hills do is you don't just send somebody to the hospital, the whole bunch of people come with you. So you have all your cousins and all your relatives. So there's a big old bunch of them that came into the hospital, waiting for her to deliver the baby. And of course, they're freaking out in the emergency room because this lady is blue. And they were thinking, oh my goodness, if the woman is cyanotic and she doesn't have enough oxygen, then clearly the baby doesn't have enough oxygen either, and we're going to have to do something. So they were all freaking out, and the people were like, what's the problem? What's the problem? And they said, well, she's blue. And they said, well, yeah, but she's always blue. And that's how they found out about the blue people of Kentucky. So they actually have a blood condition where they don't break down the hemoglobin. So if you can think about when you get a bruise and you get it's all red for the bruise where the blood's come up under the skin, and then as you slowly break it down, it kind of turns a bluish purple color. And then over the days that go by, then it kind of turns a greenish yellow color, and then slowly it goes away. Well, the people were lacking an enzyme that was able to finish breaking the blood down from the hemoglobin down into the blue color and the purple color, and then on down, they couldn't get to the green and the yellow. So the blue built up under their skin. And oddly enough, it's not dangerous, it's not toxic, it just makes your skin blue. And you can do something a little bit similar to this. If you feed your kid too many carrots, sometimes kids were actually turning orange because they had so much of the orange pigment that's in carrots that built up under their skin. So apparently the lady delivered her baby, and they realized she had plenty of oxygen. She wasn't cyanotic. Her skin just was blue. So here's some of the pictures. This is my favorite one. Here's a list of some of the things that could cause you not to have enough oxygen, which could cause you to be hypoxic, or it could make you become cyanotic. If you're at high elevation, if you have trouble breathing for whatever reason, if you have, if you've drowned, if you have aspirated a foreign body. So you've swallowed a grape or something that's lodged in your airway. For older people, it seems to be a piece of meat seems to get stuck in the airway. And then you do the Heimlich maneuver. If you put your fist under the xiphoid process and push upwards, you can actually push the air out of the lung. It should push whatever's stuck in your voice box out. So that's what the Heimlich maneuver is. And usually somebody goes behind you, puts their fist in below the sternum and pushes upward. But if you're by yourself and you're choking, you can throw yourself over a chair. And the force of the chair hitting your abdomen will push the diaphragm up and push the lungs up and push the air out. So it should pop the thing out like a little cork if things go well with you. If for some reason you have respiratory arrest, or if you have a degenerative lung disease. But I want to make sure that you know about the aspiration of a foreign body and the Heimlich maneuver to pop it out, because you can do it on yourself. With a baby, you can kind of grab them up and turn them upside down and let gravity help you with it popping the thing out. Here's a word you need to know, ischemic. Ischemic. That is where you don't have enough blood. So obviously if you can't circulate your blood, you're going to have hypoxia. So that would be in the case of congestive heart failure. You just can't get the blood going, so you can't get the oxygen going. Another oxygen depletion where you have hypoxia is if you're anemic. If you literally don't make enough red blood cells, or you don't have enough iron to build the correct red blood cells, then you're not going to be able to carry oxygen, because you've got to have that iron, you've got to have that hemoglobin. There are metabolic poisons, and cyanide is one of them. So actually cyanide doesn't kill you. The cyanide kills your mitochondria. And since the mitochondria are in there making ATP for you and using up that oxygen to make the ATP, if you kill your mitochondria, then you die too. So that's kind of interesting. And then the word cyanosis we went over. Cyan is the color, blue. So it is a sign of hypoxia unless you're in Kentucky, and it could just mean that you're one of the families from the hollers that are the blue people of Kentucky. In case you're one of those people that just want to know the rest of the story, in the case of the people who were blue, the guy at UK was thinking about it, and he was studying about it, and he found that there were some Eskimos that also had the problem. And what they did to treat them was they gave them, I believe it was methylene blue, and they literally peed out the blue. So you could just see it come out from under their skin and come out in their urine. So we now can fix it. So if you go down looking in the hollers of eastern Kentucky, you'll probably not find the blue people, because they take their medicine and they're not blue anymore. I mentioned that the air we breathe is about 20%. If you tried breathing 100% oxygen, it generates free radicals, these ions. It forms hydrogen peroxide in your body. It will destroy your enzymes. It damages your nervous tissue. It can cause seizures, coma, and death. So it's good that we only get 20%, unless, of course, we have emphysema and we have to get more because we don't have any surface area. I talked about babies being born before 7 months. They don't have their lungs formed. So you're going to have to do something to get oxygen into the baby. And one of the things they tried, they said, well, we'll use a hyperbaric chamber and we'll force oxygen into the baby's lungs. Well, unfortunately, it also destroyed their retina. So they decided that was not what they were going to do anymore with premature infants. So, like I said, we now have the fluid that you saw in the abyss, and we can treat the children, their lungs, the little babies, with that. and get the oxygen through that way until their lungs can develop and they can make their own surfactant. Here's a little bit more about COPD. It's almost always from smoking, and two of the main ones are chronic bronchitis and emphysema, but you can get it from air pollution or occupational exposure. If you've got something in the air that can destroy your lungs. But the OSHA regulations say they have to tell you if you're in a situation where you're going to be inhaling things that could hurt your lungs. And then there are some people who are, they inherit problems. So one of the results that you're going to have, if you stop and think about how the heart works, you've got the blood from the right side that's got to go over to the lungs and pick up oxygen and bring it back over to the left side where it can go out the aorta and go to the rest of the body. Well, if you can't pick up oxygen, then the heart's going to have to keep trying harder and harder to get oxygenated blood. And so you have hypertrophy or an overgrowth of the right side of the heart. It enlarges. So you can actually look at a person, a scan of a person, and you can see the right side is severely swollen. And you go, oh, yeah, this person has COPD. They're not getting oxygenated enough. But of course, you can always check their oxygen through their blood too and know that they're not getting enough oxygen. If you have bronchitis, you're making too much mucus, and the mucus is a great food for bacteria. They love to eat mucus because it's got all kinds of proteins and good stuff in there. So a person who smokes has their cilia won't move anymore. They not only don't move, but after a while they fall off. So you don't even have them anymore. So you got your goblet cells putting out way too much mucus. Your cilia can't move it, and so your lungs fill up with mucus, and you have to cough and cough and cough and keep bringing up this thick mucus and cellular debris. So you can usually tell somebody who has bronchitis by that smoking cough, and they are blue. Some more things that you should know about emphysema is we talked about the alveoli they break down and are replaced by scar tissue. You end up with air trapped in your lungs that you can't get out. So the person becomes barrel chested. Their ribs stick out really, really far. But here's the thing, they spend 3 to 4 times the amount of energy just to breathe. So where you're breathing in, breathing out effortlessly, they have to put in so much energy that every breath is an effort. Other things to know about COPD, obviously you're not going to get enough oxygen, you're going to have too much carbon dioxide, and you're going to have acidosis because that goes hand in hand with too much carbon dioxide. And when you are oxygen deprived, you are going to make erythropoietin, which is a hormone that's released from your kidneys, and it makes you make too many blood cells. So you make way too many blood cells because you think, well, maybe the problem is, I don't have enough red blood cells. Maybe I don't have enough hemoglobin. So it tries, because it knows you're not getting enough oxygen. So that hormone's going to try to fix it, but it's not going to be able to because that's not the problem. And eventually the right heart can fail because it just can't. It can't pump enough oxygen for you. Some facts on lung cancer. You have more deaths from lung cancer than any other cancer. And almost all of the deaths from lung cancer are due to smoking. The most common of the 3 major kinds of lung cancer is squamous cell carcinoma. So when you're looking at the bronchial tubes, we talk about the ciliated pseudostratified epithelium. In a person who's developed squamous cell carcinoma, these cells are replaced by squamous epithelial cells. So instead of having the columnar cells, the pseudostratified columnar cells, you have the squamous epithelium, and you lose your cilia. These cells have lost contact inhibition. They don't know where they are, so they just start dividing. And they divide into the bronchial walls, and it starts causing bleeding and lesions in the bronchial tubes. And of course, you're closing off the bronchial tubes. And instead of having functional respiratory tissue, you start putting keratin. Now, keratin is the stuff that makes up your fingernails, your hair, horses' hooves. So this is not what you want instead of functional respiratory tissue. So this one can take a while to kill you. Less common is adenocarcinoma, and it originates in the mucus glands. So you have cancer of the mucus glands. And then the least common, but the most dangerous, is the small cell, also known as oat cell carcinoma. And they named it because it looks like you've got granola in your lungs. It starts out in your primary bronchial tubes, and then it metastasizes very quickly to other organs. So when my father got the message from his doctor, he says, well, I got good news and bad news. And he said, what's the bad news? He said, oh, you got lung cancer. And he said, what's the good news? He said, oh, you got oat cell. You're going to be dead really fast. And that sounds so cold. But if you've ever watched somebody die from the other kinds of lung cancer, it's heart-wrenching. I mean, it's heart-wrenching to watch somebody die from oat cell, but at least they don't suffer but a few months instead of a few years. This says that the first sign of lung cancer is coughing up blood. Actually, of all the people I know that had lung cancer and died of it, the first inclination they had it was they had a backache. It was just a nagging backache, and they couldn't figure out why in the world. Well, their cancer had already spread into their bones. So it gets in your liver, your bones, your heart, your lymph nodes, goes up into your brain, and only 7% of the patients survive 5 years. So your prognosis is not very good. By the time you know you have it, because you're short of breath, you're coughing up blood, it's already metastasized. And once it's spread, it's really hard to kill it, the cancer in all of those places. And anytime you get cancer in the bones, it can be excruciatingly painful. Here's a picture of a normal lung. Here's a picture of a smoker's lung with the carcinoma growing in it. So here's your tumors growing all nice and pink. And that's what your lungs look like when you smoke. So I'll leave you with one last thing. A lot of people don't want to end up with lung cancer. They don't want to end up with emphysema, but they do love that nicotine. So the new thing that I've seen a lot of students doing is vaping. And the formula that they had for vaping caused what they called popcorn lung. And as soon as they found that out, they changed the formula for the vaping. But I would start chewing gum or do something else besides trying to get nicotine through smoking or vaping. And again, a lot of people say, well, marijuana doesn't hurt you, but you're sucking in carcinogens and you're sucking in carbon monoxide into your body. And actually, because you hold it in your lungs, instead of like cigarette smoke, you inhale and exhale. Smokers of marijuana inhale and try to hold it to get as much of the effect as they can. So they're allowing more of the carcinogens and more of the tars to get in their lungs. So think about how precious your lungs are and think about not even trying any of those nicotine containing things.